Hi, Peter Johns here, a retired emergency physician who likes to teach others about dizziness and vertigo. The patient who complains about constant dizziness may have nystagmus that's easy to see, as in this patient. And this is where the HINTS exam is a very valuable tool. But if you don't see nystagmus, many people find this a difficult patient population to try and figure out. And there's a reason for that. There's not a lot of good information about these patients, and what is out there is sometimes conflicting and can just make you more confused. I was prompted to make this video because a paper that was written 3 years ago, mainly by Australian neurologists, made this astonishing statement that in the acute vestibular syndrome, finding a patient that does not have nystagmus when you examine them is 100% specific for the diagnosis of posterior circulation stroke, and they described this as a novel finding. When I read this, I felt it lacked face validity. First, because in the original paper about acute vestibular syndrome by Hodson and Balow, nystagmus was part of the definition, so patients without nystagmus don't have the acute vestibular syndrome. And secondly, we've all seen patients who complain of constant dizziness, have no nystagmus, and don't have a posterior circulation stroke. So how do they find that all of them did? The second thing that got me going on this topic was when a few months ago I came across this video about the HINTS exam in the acute vestibular syndrome by an ENT surgeon who has over 650,000 subscribers on YouTube and has made hundreds of videos on vertigo, many of them quite good. And he stated in this video that a lack of nystagmus puts you more on the side of a peripheral cause of vertigo. Now in this video he doesn't say if he considers nystagmus a defining characteristic of the acute vestibular syndrome, but it would seem probably not, since he lists no nystagmus as a possible finding in acute vestibular syndrome. And also, he doesn't explain how patients without nystagmus would be more likely to be having a peripheral cause. I expect it's because about 10% or so of patients with BPPV complain of a constant amount of dizziness and they rarely have nystagmus at rest. So which statement is true? That a dizzy patient without nystagmus suggests a peripheral problem? Or that a dizzy patient without nystagmus is for sure having a stroke? And the answer is neither. Having no nystagmus in a dizzy patient certainly can be a stroke, but can also be BPPV or vestibular migraine or any of many medical causes of dizziness. And certainly seeing a dizzy patient who doesn't have nystagmus does not automatically mean a stroke. Now both of these authors claim to be looking at acute vestibular syndrome patients, so let's have a look at how they define them. And as I said, Dr. Chang did not define what he meant by acute vestibular syndrome, and Nam didn't describe what he meant by AVS in this paper. But this group has published another paper where they described it as basically dizziness, vertigo, or imbalance lasting for at least a day. No requirement for nystagmus to be seen. In any case, in the paper that claimed no nystagmus was 100% specific for posterior circulation stroke, they selected only patients who had either posterior circulation stroke or vestibular neuritis. And their gold standard test for posterior circulation stroke was MRI or CT showing a stroke. And they had 101 patients with a dizzy stroke. The gold standard for vestibular neuritis was having an abnormal bedside or video head impulse test, and they had 104 patients with vestibular neuritis. They determined the specificity using the standard equation for specificity, that is, true negatives over the true negatives plus false positives. It's the false positives that will decrease the specificity of any test. Now this is where they use a double negative. It gets a bit confusing, so I'll lay it out for you. The test that they were determining the specificity of is a lack of nystagmus. So having a lack of nystagmus is a positive test, and having nystagmus is a negative test. So the true negatives are patients who have a negative test and do not have the condition we are looking for. So in this case, the true negatives are patients that have nystagmus and do not have a posterior circulation stroke. Now, a false positive test is a patient who has a positive test and doesn't have the condition. And in this case, that would be all patients who have a lack of nystagmus and do not have a posterior circulation stroke. So looking first at the true negatives, which are patients with nystagmus that don't have a posterior circulation stroke, there were 104 patients with vestibular neuritis, of which all of them had horizontal nystagmus, and there were a couple of vertical downward torsional nystagmus, which is typical of a rare form of vestibular neuritis that only affects the inferior aspect of the nerve. The false positives were all the patients who had no nystagmus and did not have a posterior circulation stroke, and that number was 0. And using these numbers, they calculated that finding no nystagmus was 100% specific for posterior circulation stroke. But was it even possible to find any false positive cases in this patient population? Well, no, because remember, a false positive would be somebody who had no nystagmus and did not have a posterior circulation stroke. Because in their two defined populations, the vestibular neuritis patients all had nystagmus and no stroke, and the posterior circulation stroke patients, some had nystagmus, some did not, but of course they all had a stroke. So when you only look at these two patient populations, by design you can't include any patients who had persistent dizziness and no nystagmus and didn't have a posterior circulation stroke, the false positives. And when you design the study to exclude all the false positives, there's no way to find any specificity other than 100%. So this isn't a novel finding, but just the way the study was designed. Now, what might have happened if they did include different diagnoses? We get some insight into this when we look at a previous paper the same group published a year earlier. In this study, they didn't restrict it to only two diagnoses. They also diagnosed BPPV and vestibular migraine, which were in fact the two most common diagnoses, as well as vestibular neuritis, posterior circulation stroke, and also TIA and Meniere's disease. And when they specifically looked at their definition of the acute vestibular syndrome patient, they had 46 posterior circulation strokes, 61 vestibular neuritis, and 41 other diagnoses. Exactly what the diagnoses of these other patients were is not clear, but they do state that 11% of the acute vestibular syndrome patients had vestibular migraine, and that 91% of patients with vestibular migraine had no nystagmus. So it's very likely a significant portion of their other diagnoses in the acute vestibular syndrome group would have no nystagmus and not have a stroke, which if they looked for in their later study would create a lot of false positives and lead to a significant decrease in their novel finding of 100% of acute vestibular syndromes without nystagmus having a stroke. Now, why have I spent the last 4 minutes showing that this statement from a paper from 3 years ago is invalid? It's because these little factoids can live a life of their own. Look at this statement from a paper a couple of years ago, where they state that in acute vestibular syndrome, a lack of nystagmus is a highly specific sign for a central cause, as emphasized by reference 31. And guess which reference that was? Yes, the paper we just looked at. And even just 3 months ago, Barry used Worthrich as a reference that acute vestibular syndrome patients without nystagmus have a very high risk of stroke and should be routinely imaged. And there's some truth to this, that they're at high risk, but certainly not 100% risk of stroke, and I think we can do better than simply MRI every patient with constant dizziness, but not nystagmus at rest. Has there been any evidence as to what's a reasonable thing to do in these patients? There hasn't been a prospective study to look at this patient population that I'm aware of, but there's some evidence for what I'm about to suggest. And first, it's to look very carefully for nystagmus. If you don't see nystagmus in patients who have acute constant dizziness, have them look 30 degrees off to the side looking through a piece of paper, and you might see nystagmus that wouldn't be seen otherwise. And if you do see pathological nystagmus, even when they're only looking in one direction, that's the patient you can do the Hintz exam on. But if they truly have constant dizziness without nystagmus, the first thing you want to do is screen them for central features. If positive, work them up for stroke. If screens negative for central features, observe their gait. If they have a new objective gait difficulty, work them up for stroke. If they screen negative for central features, have no new objective gait difficulty, they are probably at very low risk of stroke. Now let's run through those 3 steps in detail. What do I mean by screen for central features? Those who are familiar with my videos know that I feel strongly that screening for central features is an important thing to do with any dizzy patient. And by central features, I mean things that are not infrequently seen in dizzy strokes, but are much less commonly seen in patients with non-dangerous causes of dizziness. We're all worried about missing a dizzy stroke, so you don't want to send a patient home with a non-dangerous diagnosis of dizziness when you haven't asked and recorded their negative replies about all these central features. And they are new significant headache or neck pain, which would make you think of a cerebellar hemorrhage or infarct, or a vertebral artery section, or focal weakness or paresthesias, or diplopia, dysarthria, dysmetria, dysphagia, dysphonia. Now normally on this list I would also include vertical nystagmus at rest and inability to walk unaided, but we are already saying that we're talking about patients who don't have nystagmus at rest, and we're about to look at their gait a little more closely. Mochner's study, where he looked at patients who were admitted to hospital because of an unclear diagnosis and were persistently dizzy and had an objective change in their gait but no nystagmus, He found that 33 to 50% of them would have findings on their delayed MRIs, mostly strokes, that would explain why they're having persistent dizziness, no nystagmus, and difficulty walking. So this group had a high risk of having a stroke, but certainly no 100% specificity for no nystagmus, meaning a stroke. So what I would take from this study is that if a patient is constantly dizzy, has no nystagmus, screens negative for central features, but you observe their gait and they have a new objective gait difficulty, I would work them up for stroke, yes. Now this recent paper by Smith was a retrospective study that looked at patients with acute onset dizziness who had a stroke code called on them and had an assessment by a neurologist of their gait. They included patients who did have neuro findings, and they found that if you didn't have an objective gait abnormality, that had a negative predictive value for stroke of 99%. This is probably the best evidence I've seen that if you do have a constantly dizzy patient without nystagmus who screens negative for central features and has no objective gait difficulty, they probably are at a very low risk of stroke. I hope this video will help you figure out which patients who don't have nystagmus at rest are at high risk for having a stroke versus those who are at very low risk. Thanks for watching.